the last debate in this important session about how to assess response to neoadjuvant therapy. Professor Bahadir Gulluoglu from Turkey, his opinion is not for all cases we have to proceed for MRI.
Good afternoon, everybody. Thank you very much for your kind invitation. And this is the last topic for the Congress, as I assume, about the post-neoadjuvant chemotherapy assessment. So I will start with the debate with assessing response to neoadjuvant chemotherapy, that the MRI is not needed in all cases. So here, we know that there are many studies showed us that MRI is significantly important to show the post-neoadjuvant chemotherapy responses. But I'm a surgeon, I'm a breast surgeon, so I have to look from another angle. The clinical significance is very important for us. So we need not surrogate markers like, sensitivities and specificities, but we need absolute markers, which are the endpoints and outcomes, should be regarded as the efficacy. Yes, but we'll show what I mean from the efficacy. Of course, the safety, we shouldn't forget about this, and the patient satisfaction. So that doesn't mean that when I say I found it, is it really a thing? Does it really matter? Is it worth to find it? Because sometimes we know that for any kind of imaging tool, the false positivities and false negativities are important, and I'll try to show it. For example, the MRI usage in the preoperative setting is important, but when you look at the meta-analyses, we saw that there is no difference whether you use an MRI or not, even in young patients. In these nice meta-analyses published last year, we saw it very clearly. So it's not associated with improved surgical treatment or with less involved margin or re-excision. So for what we do, why we do MRI or any kind of imaging after neoadjuvant chemotherapy, that is the clinical reasoning here that we should understand. So here, why we do it as a surgeon to obtain an R0 resection, that means no tumor on the margin. So this is very important. So why we use an imaging? To understand whether there's a complete or partial response after the treatment. If it is partial, is there any multifocality? What about the tumor size behind? Remaining tumor burden. And again, if partial, is there any local invasion remains afterwards? In St-Gallen consensus, the panel decided that you don't have to resect the original tumor. After the shrinkage, you can only resect the shrinked tumor with the, as I said, R0 resection. So this is very important for decision making to assess the response and measuring the residual disease in order to obtain this target. So the question here, which imaging tool is adequate? As I said, for the absolute markers in the real world's consequences, beyond the statistical numbers, you need a clinical significance. So we have to understand the overestimation and underestimation. Because if you are overestimating the tumor response, you can make unnecessary surgery, which means unnecessary mastectomies, large partial resections, so they can cause surgery-related complications or cosmesis-related problems. And this, in fact, hence can cause lifelong quality of life and cost issues. And if you have an underestimation, that means inadequate surgery. So the margin could be positive. There could be any remaining unseen focus or foci. They could result in recurrences, in breast recurrences, which will require additional surgeries or chemotherapies or radiation treatments. That will also, at the end, can cause increase in mortality and morbidity, in addition to lifelong quality of life and cost issues. So overestimation means the imaging tool, whatever you use, sees or reads the residual tumor, but there's actually no tumor behind, or imaging tool sees or reads the residual tumor larger than actual. For the underestimation, the tool sees or reads no residual tumor, but there is actually remaining tumor, or imaging tool sees or reads the residual tumor smaller than the actual one. So let's transform the statistical definitions to the real world. The false positivity, if there's an increase in false positivity, there's an overestimation, and the true negativity is less, then the specificity is less, then that means overestimation. And also positive predictive value is less here, decreased, so it also means overestimation. And this is vice versa in the false negative ones. So what about, let's start with the role of MRI in the assessment of axilla, because that's also important after neoadjuvant treatment. We have two clear studies which shows us one from the Memorial Sloan Kettering and the other one from the Maggie's Women's Hospital from Pittsburgh. And, sorry, I couldn't catch that. Yep. In the first one, one is prospective database. They show that the false positivity is nearly 30%. Also, false negativity is around 35%. So radiological complete response by MRI does not predict the PCR with adequate accuracy in those patients with positive lymph nodes before neoadjuvant chemotherapy in assessing the post-NAC response. So again, the second study also showed us the same. So in MRI, in the post-neoadjuvant chemotherapy stage, even by cancer subtype, they have a lot high false negativities with resulting in less sensitivities. So they cannot reliably predict residual nodal disease. Here, what we can conclude that then assessing the axilla after neoadjuvant treatment, MRI is not adequate. So what about the MRI in assessment of breast primaries? So MRI, we know that we use really common and also in my clinic, but the meta-analysis of meta-analyses, there are 4 meta-analyses until now, and they just analyze the whole data again, and they show that MRI are more likely to overestimate. That means that they overestimate the tumor response. Even there is a PCR, but the MRI says there is no PCR, or even there is a 1 centimeter tumor, the MRI says there is 1.5 or 2 centimeters, which it means for surgeon to changing the treatment plan, for the surgical plan. So the underestimation is less after neoadjuvant treatment, but I will show you in some certain subtypes it's also important. So for the PCR, because we have 2 definitions, detecting the PCR and also detecting the residual tumor burden, which is very important. It is the overestimation. When you look at this, the largest one with 44 studies, it shows that there's a definitely overestimation with less specificity. And also for the pathological breast tumor size after neoadjuvant treatment, other than the PCR, again, MRI appears to slightly overestimate the pathological size. But here, when they stratify the patients according to the subtypes with the luminal, triple negatives, and positivities, they saw that the MRI had a false positivity over 30% with less false negativity. That means overestimation. But in ER positive patients and also in grade 1 patients, there is more likely to underestimate, other than the overestimation in general. In these low-grade tumors with good prognostic features, the MRI is underestimating. So also in the diffuse non-mass-like enhancement on the initial MRI is also another important pattern which makes us to predict the response here, more likely to both underestimate and overestimate. So a good study, which is the SPY study, which is a very large study, and they stratified the images into 5. Like in the left side, you see the well-defined unicentric mass, or the multilobulated mass. They stratified into 2, and they saw that these images are correlate with the subtypes. Luminal A or B tumors are more like on the right side, and HER2 positive and the triple ones are like more on the left side. And in the end, they show that in those tumors who were luminal, they had more underestimation and overestimation, which the discordance rate is nearly 50%, which is very significant. But in those patients with triple negative tumors or HER positive tumors, the discordance a little bit less, but still there is a discordancy towards overestimation. So let's see what about the breast ultrasound, to compare with MRI here. So the first study is coming from the United States, again from Pittsburgh. So the false negativity and false positivity seems similar with the ultrasound and MRI. And even in the young and the elderly patients, when they stratify according to age, as you can see here on this slide also, ultrasound in both age groups is superior by means of accuracy to MRI. And also another study from Tampa, again, United States, although the sample size is a little bit small, both the 2D and 3D, I'm excluding 3D, but because the conventional ultrasound is a 2D, is non-inferior in the prediction of residual disease. So these two studies also says that the MRI are suboptimal predictive, have a suboptimal predictive value for complete response. So what about the correlation between the MRI and pathology? This is the intense study from the Netherlands, and in MRI overall more likely to overestimate and less likely to underestimate, which reaches up to 1/3 of the patients, and more likely to overestimate in, again, which is concordant with the previous studies, HER-positive and triple-negative patients. But what about the comparison with the ultrasound and MRI? Let's look at details. For the accuracy, both the MRI and ultrasound seem similar. Overestimation seems similar, although there is a slight difference against MRI, but I'm saying equal. Underestimation seems equal. For the hormone-positive patients, again, the accuracy is a little bit higher for ultrasound. Overestimation and underestimation looks similar. And for the hormone-negative patients, again, the accuracy is a little bit higher for ultrasound, and also the overestimation and underestimation seems very much similar. So overall, there is no difference between ultrasound and MRI. Another meta-analysis also showed that for detecting the PCR, not the volume after the neoadjuvant chemotherapy, that the MRI had higher accuracy than mammography and physical examination, but there was no difference between MRI and ultrasound. May I remind you that this is the meta-analysis and not only on single studies. So another meta-analysis from the same group said that comparable performance by MRI and ultrasound to estimate the remaining tumor size, not only the pathological complete response. So in this trial, in this meta-analysis, they just compared the ultrasound, the MRI, physical examination, and they showed the similar overestimation for MRI and ultrasound. So, as a conclusion, what about MRI after neoadjuvant treatment? Is it really necessary, or can we use another tool instead of MRI? Well, we can say that it's not necessary in cases initially multicentric. You already decided that you will do a mastectomy after neoadjuvant treatment because in the beginning it's multicentric. And already feasible for breast-conserving surgery, but initially N positive, and you're just giving the neoadjuvant treatment because there is the N positivity, and I showed you that the detection of the status for the axilla after the neoadjuvant chemotherapy is not so good by MRI assessment. And also, it's not useful, MRI is not useful, probably of leading to unnecessary surgery in cases ER positive and luminal tumors with an underestimation, and low grade, also it's the same for low grade. And as I showed you with the meta-analysis and 2 and 3 studies, it's not superior until now to ultrasonography in cases triple negative and HER2 positive cases. So there's no randomized study compared MRI to another tool or physical examination only until now. Main outcomes, if you would like to, plan a study for future, the main outcomes, as I said, the real-world consequences should be considered. So the main outcomes should be local recurrence-free, breast cancer-specific, and overall survival, not only specificity and sensitivity. And the secondary outcomes should be re-excision and mastectomy rates, as well as quality of life parameters, as they done in COMET study, MONET study, and POM study. So the conclusion, ladies and gentlemen, considering evidences, no definite conclusion can be drawn to promote MRI as the preferred tool for post-neoadjuvant chemotherapy assessment in all cases, not in every case. Thank you very much for your attention, and I would like to invite my opponent.
Thank you, Dr. Bahadir. Let us listen to the other opinion from Professor Jane Sally from Canada. supporting MRI imaging for assessment of neoadjuvant chemotherapy for all